It is working though.
Okay. I no longer have my notes. I'm going to try a different way to share. Apologies. Oh, wow. Okay. Do you see my speaker notes? Okay, even better.
Nope, just the presentation.
I tried a different way. Perfect. So thank you so much for having me. My name's Tina Burnett, and I'm a manager at the Northeastern Public Health Health Unit, and I manage the Healthy Families program. I see a lot more familiar faces than I thought I'd ever see at this table, so I was thrown a little off there. I was like, okay, I'll present to a whole bunch of people I haven't necessarily met, but this has really changed the game. And I was invited to speak today as part of the Hot Topic series on our CBFI-c journey. I did choose, and I hope this is okay, to specifically focus on our experience at the front end of this and our decision making about participating, the timing, decision making, what it was like to say yes to this work during a time of significant organizational change. So I'm happy to answer any technical questions about our project, but the next 5 minutes will really be on our journey at the beginning to decide on participating in this worthwhile project. Just a little bit about us. So Northeastern Public Health has brought together the strengths of legacy Porcupine and legacy Temiskaming health units. So as of January 1st, 2025, we became one. So our new region, you can see with the green arrow, we do have the largest landmass for health units in Ontario. And this is just a little bit about us. We do have a high Indigenous population, a high Francophone population, and I've put 33% there. It is important to note that in some of our communities, it's as high as 80%, depending where you are in our region. And same with the Indigenous population as well. That can really significantly increase depending where you are within our region. We do have some higher teen pregnancy rates compared to Ontario, higher rates of substance exposure during pregnancy, and higher rates of mental health concerns for those who have given birth. When we look at breastfeeding specifically, so I'm not going to spend too much time on this, but just to give you an idea of the context of our region, we do have, there is a lower intention to breastfeed found in NEF. More infants are being fed formula only. However, change is occurring for the better. So when we look at the rate of our change of initiation rates, it's increasing higher than the rest of Ontario if you plot out those lines. So that's exciting for us. There's definitely an opportunity in our region to support better informed decision making. We have a lot more moms going into birth choosing not to breastfeed, so and making or being undecided on how they want to feed their baby at birth. So we see a definite opportunity there. And it is important to note that there's actually a discrepancy in some of our numbers and rates between the two legacy health units. So it's really looking at the strengths in the southern region of our district and hopefully being able to apply some of the great interventions that have helped maintain their initiation and duration rates. So unless you've been in a merger, you just don't know, and I didn't know either until we were put in one. And it is important to understand this a little bit, that it does mean that we're dealing with a lot at the same time, and it's not one change at a time. So when we merged on January 1st of 2025, we were still completely in parallel processes. So we had two Healthy Families teams that were functioning the way that they always had, and that was duplicated across the organization. Everything has to be harmonized. Our infrastructure, our IT, so even something as simple as using SharePoint. Well, if that wasn't what each agency used, and that can really overhaul people's morale, people's ability to do their job as efficiently as they did before. So there is definitely, you experience a huge regression in the early parts of merger because everything actually takes double the amount of time. There's 2 processes for everything. So I just want to give you a snapshot. Also, for our merger, we introduced a new leadership structure. So that also was some change. And something that I never once considered, but that's very forefront, is when you merge as well, you're dealing with multiple collective agreements that aren't harmonized. And so working with staff on the same team who are getting paid different, who have different statements in their contract that allow them to operate very differently is also something that you endure, I guess, during a merger. Now I'm going to get to the good stuff. Sorry, that was a little bit heavy, but so initially, and again, I'm taking us through kind of our decision making, how we decided to move forward, even during a huge change for us, a period of instability for us. So initially, our team was really unsure about whether participation was appropriate, given everything that was happening internally. I was definitely asking some questions about readiness, alignment with our current work, and whether we actually could meaningfully engage without overextending my staff and my team during this critical transition period. Capacity was a huge concern. With teams merging, oh, actually, you know what? I skipped a really important slide. I'm going back to this because I'm like, you guys don't know our timelines, but let me show you. Apologies for that. So our official merger date was a year ago. So we celebrated our 1-year anniversary. We're doing open houses right now in all of our 13 offices. So that's exciting, but we did merge a year ago. We were notified of the opportunity to participate in it kind of fell on, it came from nowhere for us. It may have been on other people's radars, but we weren't expecting this. But we were made aware in May that there was this pilot project. As you can see on this timeline, this was only about 4 months after we merged, or 5 months after we were one organization, and my team still hadn't merged. So my team was due to merge, so to all report to me. We still had, parallel processes in June. So a month when we learned about this, and really only 3 months from when the project, or 2 months from when the project was supposed to start. So the timing of this opportunity really shaped how we approached the decision. It wasn't an easy one. We were really trying to balance the system merger, an upcoming team integration, and really the question of whether or not we had the right capacity. So back to my initial considerations. So these were the concerns that, as a manager, I had. And at first I was honestly like, we can't do this. Like, it's just not the right timing, but I kept going back to it and being like, oh, but could we? So we really were uncertain about the appropriateness of participation. And it wasn't that we didn't think we would gain anything from it. I need you to know that. It was, we didn't know if we could contribute to it. We knew we would gain, it was a great opportunity, but we didn't want to be a drain on it and only be taking and not really be able to meaningfully contribute. So these were all of the things that were really making me think that we wouldn't be able to. However, there's a flip side to that. At the same time, we knew one of the first things that was evident in this was that the goals of the CBFI-c lined up well with our values, supporting families, using evidence to guide practice, and focusing on system level change. I also saw this as a chance to build quality improvement into our work early on, because I have a huge task with my team ahead of us, which is aligning all of these parallel processes. So I knew I had to harmonize all of my policies, how we did our work anyways. So instead of waiting till everything was settled and then looking at trying to improve our processes, we did see it as an opportunity to do it early on. The other piece that I was really drawn to as a manager was having a shared project. So something that didn't belong to either legacy health unit, but that was brand new early on for both of us. So as we were coming together as a newly merged Healthy Families team, having a shared focus and a project that belonged to us as a whole was really appealing to me because I didn't have that anywhere else. And then obviously the long-term outcomes and what we knew how this could support us as an agency was obviously something that we saw as an opportunity. This slide reflects a learning from our merger process. So we have hired some consultants. I think many health units in the same that are merging also have some consultants. Ours is Leaders for Leaders, and they have been supporting our frontline staff as well as the leadership team in giving us tools in our tool belt to help cope with the change, anticipate how people might be feeling in the change. And one of the things, the key messages that they've given us is healthy tensions. So they're the product of opposites that emerge during change. So when two things are both true, important and valuable, yet pull in opposite directions. So when this invitation arrived to participate, I initially experienced it as either or. And to be honest, my first gut reaction was, I don't think I can do this. I don't think I have the capacity. There's so much uncertainty right now. But again, the nagging feeling wouldn't go away that I actually knew the value in it as well. So instead of thinking of it as an either or, it was important to look at as an and, that both of these things are true, but that we could still move forward. We also did call a friend, Emma, because I really was still hung up on this appropriateness that we knew we would gain things, but we wanted to be contributors as well. And we just weren't sure how this would work when none of our baseline data, it's like comparing apples to oranges. We're now one agency, we weren't. So how do you, even from a data perspective, look at that? So, and she did help us, lean into these healthy tensions and recognize that we were able to participate in a meaningful way and contribute with a different lens. So that was exciting. So I guess in summary, what helped me as a leader in our organization move forward with this opportunity in spite of all of the uncertainty and the change we were going through are that values really helped us. Going back to our guiding light of what we were trying to accomplish really helped make it very clear that we couldn't pass on this opportunity. And this process reminded us that good public health decisions don't always feel easy in the moment. And discomfort doesn't always mean something's wrong. It often means we're being careful and responsible, but because it would have been really easy for me to say no, to be honest, that it wasn't the right timing. But I had to lean into that being uncomfortable and, oh, can we do this? The one thing though is that it's always important, what I've learned and we've put in place in this project is the opportunity has to match capacity. So saying yes responsibly means paying attention to staff workload, readiness, and what we could realistically take on during this change. And I did have to align staff to this. And that was a conscious decision that we had to make to make this work. The other piece, it wasn't just about frontline staff. For me to be able to make a thoughtful decision, I actually had to take a pause. So I needed the capacity to take a pause and really look at all of the impacts of this particular decision. Yeah, so those were my takeaways from this. Are there any questions? And I recognize my angle was slightly different. And I didn't talk to anybody about my angle. I went rogue, but we are pleased to be part of this journey and I'm happy to answer any questions.
Thank you so much. Yeah, I love your angle. That was incredibly insightful and inspirational. And I know that there's 3 of us on the executive who actually fall within the NEF region, and probably more so on this call that do. And so it's incredibly exciting that our area is part of this project. So thank you so much for putting that together and taking the time to come here and present. I'll leave it open for questions for another minute or two. Feel free to put questions in the chat. We can always loop back to you after Laura's presentation if there are outstanding questions for you, Tina, and then answer them then as well. But feel free to unmute yourselves or put your hand up if you do have any immediate questions. Put them in the chat, whatever works.
Thanks for your comment, Allison. Allison used to be part of the North. So strong connections there.
Okay, at this point in time, I'll call on Laura. Again, if there's any questions, please feel free to put them in the chat for Tina and we can come back to them after Laura's presentation. But I'll hand it over to Laura from the Black Creek Community Health Center.
Hi, everyone. Can you hear me okay? Yeah, okay. So I don't have a presentation. I was told that, oh, no, it's fine. You'll just chat for a few minutes. So, so I'm just going to tell you about our project. And so it's a little bit different. We're a community health center in North York. That's in the northeast end of Toronto. And it does have a little bit of history of, lots of challenges with a diverse population, with many health needs, disparities, and some definitely low income, food insecurity. We're dealing with those kind of challenges all the time. It's a predominantly Black and Spanish speaking area with a lot of undocumented families. So we support families without documentation, especially with our midwife. So we have a midwife, we have primary care team, which includes NPs and doctors. And we have what's called the integrated client services team, which is what I'm part of. Okay, so actually at Black Creek, so Black Creek has been around for about 30 years now. And for about 20 years, Black Creek has had an IBCLC, so an International Board Certified Lactation Consultant. And it has always been a non-RN position. Okay, and I think that's important because I think during COVID we saw that if there is an RN position for breastfeeding and we have a problem and all the RNs are going to do the things that RNs need to do, we're going to lose lactation, right? It's going to be the last on everyone's list. I personally I'm not an RN, as they said, and I come from actually a chemistry background. So a little bit different area of work now. And so that position, the lactation consultant position at Black Creek, is there because our leadership, our executive director and our clinical director really advocated for it. Okay. So I think that's really important. So this, asking to be part of this was, I feel like, a no-brainer for our leadership. And so I've been well supported with it. We do have a fairly small team. So because I am the full-time lactation consultant, I do have the ability to, block some time, or I was working from home on Friday, so I'd use that for a lot of the work. And we already have a parent partner. We have our, actually a few people, almost every meeting, a few people reach out to me from our clinical team and say, hey, I'd love to help. But as you know, kind of some of the just red tape around, you have to ask your manager and get an okay and all that. So that's been really exciting to see that a lot of our clinical team, a lot of my colleagues are really happy to support families, right? They understand that these families are facing a lot of challenges, and breastfeeding is kind of one of those perfect preventative measures, right? It's when we have food insecurity, when we have other challenges with disparities, we can kind of help to level the playing field a bit. So we already had some of the things that we've worked on so far. We did what we were suggested to do, get that low-hanging fruit. So we've updated our breastfeeding policy, which needed just a few tweaks, but we had not posted our policy. So it was really interesting to see, the first part was kind of like seeing like where you are, like, are you doing some of these things? And I think one of the things that really opened my eyes was, yes, I'm doing these things. I'm talking to families. I'm going to, a lot of groups run by the Canadian Prenatal Nutrition Program in collaboration with the Sick Kids Center for Mental Health in our area. But am I documenting it? So I think that was a big takeaway for our team as well, right? I had to update some of my templates and some of my when I go to groups, like writing in, like, what did we talk about at that group, right? And a lot of that came from doing the chart reviews. So I would say that was, I think, the biggest help doing chart reviews. I've done about just over 50 now. And that was one of the things that I could really see, I know I talk about this a lot, but I didn't write it down. I didn't send them a handout about how to prepare formula safely if they're using formula, how to wash or sterilize bottles if they're using formula. So it kind of gave me one of those PDSA cycles to be like, okay, that's something I have to add to my template. The other thing that's a little bit unique as well is we do have kind of 3 streams of clients. So we will have clients kind of in a larger catchment area that will see our midwife. So if they can get to the midwife and come to the appointments, she will see families, and usually they're undocumented, sometimes very late to care. She does not do births, so she will refer to an OB or our community midwives, which are West End midwives in the area. And I will also see those families. So, for example, if she sees them prenatally, I try to see them right after that appointment so they don't have to come back again. I do have translation support as well available to me. And Romina, my other partner on the team, that her and I are kind of leading the team, she speaks Spanish as well. So that will be very helpful for us. We also see primary care clients. So that would mean, so say someone is pregnant, they see an OB or a family doctor outside of our primary care. They don't want the midwife, or they can't see the midwife. Then they will come back into our care for the baby, and our primary care team will see the baby for well baby visits. Or if they are with our midwife, then about 8 weeks, they will see our primary care team for all those well babies. And the team knows to always reach out to me to see them for feeding, because as we know, feeding does not happen in 15 minutes. So I'm able to take take a little more time with families, and there is no limit to my support. So at 6 weeks, the midwife, is done with the family. They'll get transferred to, if they live in our catchment, to our primary care team, or she'll refer them to a pediatrician or family doctor in the area because the baby will have OHIP. But that's where her care usually ends. My care, I let families know, you can reach out, you're ready for solids, or anything changes, or anyone tells you to stop breastfeeding, I say, come on back. And then I can also see clients, there's no real catchment for me. I can see clients without OHIP or anything like that. A lot of times like I said, our community midwives, they will refer to me if they are having, kind of a out of normal scope breastfeeding challenges for a client. And the hospital will also refer to me because I do have the ability to, I have some extra training in flange fitting, and I have the ability to have flanges on site. I did get a large donation of pumps as well. So I am able to put in an order for flanges, multiple sizes, and then flange size, and give pumps as needed. And what else? So I guess our next goals are, main goals. I would like to know, like, what are our providers' skills? So we already have some great surveys all lined up. So that's why I say, like, my biggest takeaway of this project is also like I would say a lot of the hard stuff has been done for us, right? Our surveys are done and that kind of thing. It's really like figuring out how do we get these surveys completed by families. Um, and one of the things we decided was that we would have Romina, our registered practical nurse, call families, especially because she can speak Spanish. A lot of them speak Spanish. But if they don't, we can use translation and she can call them and do the survey with them. We had talked in one of our data management information sessions about, this is, ideally we have families do them by themselves, but it can be challenging, right? You have a new baby, you have, maybe other children, and you want to talk to someone on the phone. So, we're thinking that that's going to get the best buy-in, the best, kind of number of results. And because Romina is not someone they would normally see, it's not like I'm calling them and they feel like, oh, I have to say, something nice or whatever. So that's helpful. And I would like to have a little more of a better relationship with the hospital. As is, they refer to me, but we don't really have we're not on any teams together. They don't, until recently, they weren't aware that we did prenatal classes. So I always send them our information and say, hey, we're looking, this is where families are going. They're coming to us after they have the baby. So, I'm really trying to keep that lines of communication open. And unfortunately, my LC that was at the hospital, she went on maternity leave. So we're kind of dealing with less ability to, see families at the hospital. I don't believe they filled that position, so they're not able to see families as often. So they will refer to the community health center because they know there's no OHIP needed, no referrals as well. I think that's a huge barrier that will slow down the process. We do have a referral system called People Accessing Care Teams. And although my lactation is on there, I always tell families don't use that because the problem is it comes into one repository. And if we're behind, our team is behind on checking those, they could have, I've had situations where a referral for breastfeeding sat for like 6 months and the person had like an abscess. So, and when I finally called them, I was like, they're like, yeah, I needed to get help somewhere. And I'm like, thank God you did, because that is a system problem, right? So that's one of those things that, I've been trying to work with that team and be like, take lactation off of there because providers are getting confused that they can refer this way and someone will be seen quickly. So we're working on trying to update that and get ahead of it a little bit faster. So anyway, so that's it from me. I don't know how long I talked for there. If anyone has any questions or feedback or anything, that would be great. I am really loving the project. And I think it's really helpful for our team. So I'm happy to be part of it.
Thank you so much, Laura. There was one question in the chat that I saw pop up. Victoria said, is the updated breastfeeding policy available on your website? She said she did not see it, but would love to see an example if that's a possibility.
Oh, yeah. Yeah, I don't know. I don't know. I don't know if that's an indicator that we have to have it on our website, but we will have the posters. Again, these things take time. I have to deal with the communications team. And I'm hoping to get those posters for clients to see in and in each room as well. So that clients, if they come in for another reason, for health navigation or social work, they can also see, oh, this is, part of what's available here as well. But yeah, I will look into that. I would say our website is a little bit challenging to find things. To find even what's available as far as when our classes are and things, but once you know where to look, it's fairly easy.
Well, thank you so much for coming and presenting. Wow, cannot talk. It's Friday afternoon. It's really interesting to hear like the two very different perspectives and different processes that are going on kind of, you know, quite a distance apart in the province. Yeah, I really cannot speak. Sorry, guys. Is there any other questions for Tina or Laura? I'll give it another minute or two and then we'll get into our agenda. We do have quite a packed agenda today, so we will do our very best to get that all done within the 25 minutes, but do know that we may just go a little bit over. If you're not able to stay, that's okay. If you are, that's great too. But we'll try to get through it as quickly as possible. All right, not hearing any questions. I am going to turn off the recording since we're done with the hot topic presentation. Thank you